places. These are all one place where there is no wire involvement. So along the entire course of the tube, at the level of connector and at the level of tip below the Murphy's eye, there won't be wire reinforcement. So those are all the 2 places where there is chance for kinking. As I said, these are kink resistance, but these are all not highly mechanically not resistant. So this is one situation where a patient flexor metal tube was used and the patient had bitten the tube. So you can see this, since these metal wires can offer some resistance. Muscle is the strongest muscle in the body. So when the patient recovers from anesthesia, they might bite the tube. In case if it happens, it produces complete occlusion. It will not regain its original position. So it produces complete occlusion. So remember, the most important point is whenever you are using a flexometallic tube for patient, you are supposed to put a bite block or airway. That is very mandatory. So now coming to the other important invention, which I feel, it's a micro cuff tube. So previously, up to 8 years of age, we try to avoid cuffed endotracheal tubes in pediatric patients. But the reason being that is, we all know as of now, the subcricoid region is the narrowest part in the pediatric airway. So when we are putting a tube and inflating with the cuff, so when the cuff pressure is going to be high, it is going to provide some sort of injury and edema in the subcricoid region. Since being it is very narrow, when the edema is there, it is going to increase turbulence for the flow, which in case increase the resistance. Whenever there is a decrease in radius, it increases the resistance by 32 times. That is twice that for adult. So being a narrow airway, when we put cuff and inflate, the chance of post-extubation croup is very high in pediatric patients. That's why we have devised this micro cuff tube. So the important part is, compared to the normal cuff, which has a cuff of 50 to 70 micrometer, this micro cuff tube is the polyurethane foil is only 10 micrometer, and it usually forms a uniform enlargement. Instead of a short contact, it forms a uniform cylindrical enlargement. That is a very important thing. The second important thing is, the cuff is very short and it is very placed distally to the tip of the tube, and they have not placed a Murphy's eye in this tube. So what is the advantage of this? Let me see through this video. See, you can see this is a micro cuff tube. So the most important part is, here you can see the marking for this is the marking where when we are intubating, we are supposed to keep it at the low vocal cord. Here you can see, instead of here, this is the portion of the endotracheal tube going to be placed in the subcricoid region, which is the narrowest part. When there is a cuff at this place, it is going to create problem. Whereas in this situation, the cuff is distally placed and the cuff is small, short, so it is not going to produce any damage when there is inflation. So this is a comparison between the 3 tubes. This is the uncuffed tube. This is a normal Portex cuffed tube. This is the cuffed micro cuff tube. So here you can see, this is the point we are going to place the tube in such a way the vocal cord is retained. So in a normal tube, just below the level of vocal cord, the cuff is there, and the inflation of this creates a edema at the level of subcricoid narrowest part. Whereas when we use this micro cuff tube, here you can see it is placed very distally, no Murphy's eye. And see, you can see the enlargement of the tube also. This micro cuff tube, it's elliptical enlargement, in which in case the contact point for the cuff with the trachea is here. So it is going to exert more pressure at one point. Whereas here it a uniform cylindrical enlargement. So it is going to produce, when the same pressure is applied over a wide area, the force is going to be very less. This is the physics behind this. So distal placed short cuff is going to provide advantage. So again, and also this micro cuff is going to form a uniform, very thin contact with the tracheal mucosa. That is also one reason the chance of reintubation. The study shows that the chance of reintubation very, very low with micro cuff tube, and also the post-extubation croup. So remember again, when you are using nitrous oxide in pediatric patients, when you are using cuffed endotracheal tube, irrespective whether it is micro cuff or normal tube, you are supposed to monitor cuff pressure periodically. So this is the picture. So you can see the normal tube, the length of the cuff, and the distance below the level of vocal cord, where the cuff is placed. Whereas here, this is the level of vocal cord, and this is the length of the tube. So the subcricoid part is going to be free. There is no cuff at the level of subcricoid part. So moving on to Next important tube is ray tube. So there are two types of ray tube. Ray tube is nothing but ring Adair Elvin tube under the name of three persons who invented this tube. There are two types of ray tube, north facing, that is nasal, and south facing oral tube. So why there is a need for ray tube? This ray tube comes under the category of preformed tubes. Remember, suppose when these ray tubes are invented for a purpose, because suppose consider a surgeon is doing a cleft lip surgery where you are supposed to identify the symmetry of the lips on both sides. If you are fixing the normal tube and you are fixing a normal tube at angle of mouth, it is going to alter the symmetry. So during surgery, the plastic surgeon will not be able to identify which is correct. So simultaneously, if you use the normal tube and fix it at the midline, so the need for fixing at midline occurs. And when the normal regular tube is fixed at the midline, it is going to produce a compression. So when it is getting compressed, it is going to increase resistance, and there is a problem of inadequate ventilation. To avoid this ray tube has been designed. So it is a preformed curvature. As I mentioned earlier, the normal tube, when it is fixed or curved like this, it is going to reduce the airway tube, and it is going to increase compression and resistance. At the same time, this ray tube, since it is preformed, it is not going to provide any amount of resistance in the entire course of ventilation. So the second important thing, the most important thing when you use a ray tube is the size. So we cannot follow the normal measurement because the preformed portion is fixed. So you are supposed to fix, when you are using this oral ray, you are supposed to fix this at the level of incisors, and it will be above the mentum. Then so the airway need not be same. The length of airway need not be same for a particular patient. So it might vary. So for some patients, the same 8 size tube, for some adult patient, it might be too long. For some adult patient, it might be too short. So this is the way you are supposed to fix the oral ray tube. See, the curved portion where the marking is there, it has to be fixed at the level of mentum. For a nasal tube, it should be fixed like this. Suppose we get a situation like this, like the tube is inside and bilateral entry is there, but it is too long. So the most of the part is coming outside, so you will not be able to fix appropriately. So you are supposed to put a smaller size tube. Remember, the patient airway is too. So remember, the patient airway is too long. So here you can see most of the curved part is inside the endotracheal tube. So you are supposed to go for higher level of ray tube. This is one of the biggest disadvantage of ray tube. The other disadvantage is, since there is a curvature, preformed curvature, suctioning is going to be difficult. Placement of stilettes is going to be difficult. And when we are ventilating a patient, at the end of the procedure, the patient is breathing spontaneously. It is going to increase resistance and increase work of breathing. So coming to the double lumen tube. This is not a mandatory to know, but I'm going to enumerate a few points about Robertshot type of double lumen tube, which is commonly available tube. It is available in two different forms, that is right and left side. So now let us see. See, this double lumen tube consists of two tubes which is sandwiched to form a single tube. And you have two channels. One is tracheal channel. The second thing is bronchial channel. Here you can see two cuffs in this tube. One is blue color bronchial cuff, which is the peculiar of this is a high pressure, low volume cuff. You are supposed to put 1.5 to 2 ml. When you are inflating with more ml, it is going to produce damage. Bronchial rupture can occur. The second thing is the tracheal cuff. This is like the usual cuff. It is going to be placed above the level of carina, and you can put around 8 to 10 ml of air. So this is the routine high volume, low pressure cuff. You can see two openings. One is in the tip. This is going to open at in the level of bronchus, and this is going to open at the level of trachea. So other than this, you have the similar number of markings, that is 37. This is a 37 French left-sided Robertshot type of double lumen tube, where you can have the markings for fixation at the level of incisors. And it is, see, they have differentiated for differentiation purpose. The entire bronchial channel is blue color. You can see the blue color here. You can see the blue color pilot balloon. You can see the blue color cuff, and you can see in some manufacturers this itself is blue color, so that we can easily differentiate. Why it is being designed like this is because, see, whenever you are intubating the double lumen tube, even though there are conventional methods of checking, the most confirmatory method is you are supposed to use a fiber optic bronchoscope and exit out through the tracheal lumen while ventilating the patient through the tracheal lumen, when it exit out, you are supposed to see the blue colored cuff entering into the bronchus. This is the best way for appropriate position of the endotracheal tube. For that, for easy identification, they have designed it as a color-coded endotracheal tube. So, how to differentiate? The common question which will be asked is how to differentiate whether it is a left side or the right sided double lumen tube. Even though it is mentioned in the double lumen tube, you are supposed to identify by two types. So when you hold the tube in the hand, you are supposed to hold in such a way the concavity is facing upwards. When the concavity is facing upwards, the tip of the tube will project towards one direction. If it is directing towards left side, it is left sided. The second thing, if it direct towards right side, it is right sided. The second thing is you are supposed to closely monitor the bronchial cuff. So if you see the bronchial cuff, this cuff is unique and it does not have any hole. In case of right side double lumen tube, this cuff itself will contain a hole and the cuff will be donut shaped. When you inflate the cuff, it will be donut shaped because of the hole. The hole is for ventilating the upper lobe right side bronchus. So we all know most of the time we use left side double lumen tube. Even we are going to ventilate right lung, we are supposed to use double lumen tube because of one word, that is margin of safety. The margin of safety is what it indicates is the amount of tracheal tube below the level of vocal cord. At the same time, the amount of bronchial tube is appropriate place so that adequate ventilation of all the lobes of the lung is ventilated. That means there is a difference between branching for the right and left lobe. For the left, in considering the left lung, the upper lobe bronchus takes off at 5 centimeter, whereas in the right side, it takes off at very short distance, that is 2.5 centimeter. So when you don't place the right side double lumen tube properly, there is chance for obstruction of the right upper lobe bronchus. Whereas in left side, since the margin of safety is very high, which is a 5 centimeter, the chance of obstructing the upper lobe bronchus is very, very less. That's why, unless for specific peculiar indication, we will always prefer right-sided left-sided double lumen tube. Size selection, it is always based on the height. But what does it indicate is based on the height, there is a relationship between the bronchial diameter, especially in male patients. For every 25 years of age, the study says that it is increasing in enlarging in size. And for male patients, you always select if the height is more than 160 centimeter, it's 39. More than 170 centimeters, 41 size French tube. Less than 160, 37. Whereas in female, we always prefer 35 or 37 based on height, whether it is less than 160 or more than 160. The other thing is depth. The depth is always, there is a difference, but it is not of much importance because we are going to identify whether all the lungs are separated, then we can fix like that. So coming to for completion's sake, the one more important tube which we forget nowadays is Combitube. Because nowadays in difficult airway society and the algorithm itself, the Combitube has been removed. But to my knowledge, it's one of the very valuable device, can save a patient at times because this tube is unique. It consists of 2 separate channels. You can see here, there are 2 separate channels. This one channel is for blue color channel with blue pilot balloon is for one. This is in between the 2 cuffs. The other channel is below the cuff in the tip. So what happens is, so when there is a CVC situations, we need not look for any other things. We can open the mouth and we can put the Combitube inside. So that can go into either into esophagus or trachea. So what we are going to do is after insertion, we are going to inflate this pilot balloon with 8 to 10 ml of air and this with 85 ml of air. So this is going to be in the pharynx, oropharynx or nasopharynx. It is going to produce a seal and this might be inside the trachea or esophagus. So we are going to ventilate this first. When it is in the trachea, we will be able to ventilate and we can ventilate this through this lumen. When this is in esophagus, what we are going to do is we are going to ventilate through the other lumen. You can see this is the closer picture where you can see multiple 4 to 8 openings are there. So this tube provides adequate seal. Suppose if it is inside the esophagus, this closes the upper esophageal sphincter and this closes the nasopharynx. So whatever air coming through this will enter into the trachea. So this is also a very valuable device in difficult airway management. So coming to the other important thing is airway. Airways, we have oropharyngeal and nasopharyngeal airways. To my knowledge, next to mask, this is the most important device. The aim of the device is to lift the tongue and epiglottis away from the posterior pharyngeal wall so that upper airway obstruction is avoided. So coming to the part of oropharyngeal airway, this is the picture of oropharyngeal airway where you can see the flange. This is the body, or this is the channel. So it is a hollow tube which is curved according to the anatomy of the patient's airway. So if it is ideally placed, it is going to create a channel so that the tongue and the posterior pharyngeal wall is separated and there is easy passage of air will be there. So these are all the available sizes. Commonly we use this green color, that is size 2 airway for adult male and female. Whenever you think the airway might be long, you can use higher sizes. Most important thing, as I said earlier, is the appropriate size of airway. When we choose an airway very small, it is not going to solve the purpose. At the same time, when you choose airway of bigger length, it is going to provide itself with an obstruction because it may push the epiglottis into the vocal cord over the glottis. So there is obstruction. So the ideal way of checking is you are going to place it at the level of the flange, at the level of incisor. The tip of the airway should be at the level of mandible. These are all some of the examples of intubating airways, because suppose in case you are using fiber optic bronchoscope and you are choosing an oral intubation, there is every chance for the patient to bite the fiber optic bronchoscope. So these are all the available intubating airways, that is Berman airway, Ovis sapien airway, Williams airway, and Patel-Syracuse airway. Of this Berman airway, one peculiar thing is you can retain the airway itself after intubation itself with the tube in place. This is channel for tube to run. The other airways we are supposed to remove by some means. So these are all the available intubating airways. Coming to the nasopharyngeal airway, the one biggest advantage is compared to oral airway, this is going to provide less stimulus of reflex. So the tolerability of a semi-conscious patient for this airway is going to be high. Again, the appropriate size is we are going to place it at the level of the flange, should be at the level of nostril, so that the tip of the airway should be just before the tragus. So these are all the examples, and this is one of the unique one which is where there is adjustable flange. So if it is of little big length also, we can just adjust it preoperatively. We have to mark it and we can place it and we can fix the flange at that level so that there is less chance of misplacement. Coming to the other adjuvant devices for difficult airway management, that is, this is endotracheal tube introducer, commonly called as Bougie. So these are all the commercially available types of Bougie, gum elastic Bougie, Frova, Cook Medical Airways, and the other intubating introducers. In pre-video laryngoscopic era, it is one of the common devices which we always have in our hands. So it is one of the very important devices which is going to help us in management of difficult airway. The tube length will be usually of 60 to 70 centimeters. The most important part of this is the distal tip. This tip is called as Cody tip because there is an angulation of the distal tip. So here you can see in this picture, the distal tip is slightly angulated for 30 to 45 degrees. So the importance is when you are intubating with the Bougie, ideally you are supposed to have an additional source of person for railroading the endotracheal tube over the Bougie by Seldinger technique. So what you are supposed to do is you are supposed to introduce the laryngoscope, then introduce the Bougie. Sometimes you can railroad the tube already, or you can introduce the tube Bougie first. So this is very useful in situations like Karmegam 3, where you are able to see only the tip of the epiglottis, or in Karmegam 4 grades, where you are not able to see any epiglottis at all. So what you are going to do is very close to the laryngoscopy blade, you are going to advance the Bougie. Because of the anterior direction, it might go anteriorly. So you can't do much manipulation, but once it goes anteriorly, it can enter. If it enters into the trachea, you might get a gritty feel because of the placement of cartilages in the anterior part of the trachea. That's why you are supposed to orient in such a way that Cody tip is anteriorly placed while you are intubating. So you will get a gritty feel. The second thing is you can introduce to some extent to 35 to 40 centimeter, and there will be some sort of resistance after some point. When you feel resistant at 35 centimeter, it means that it is going into either one of the bronchus. That's why you are feeling the resistance because of the cartilage rings. Whereas in case if you enter into the esophagus, it is being a hollow structure and a soft structure, it is not going to provide any amount of resistance and it will go entirely even after 40 centimeters. When it is going beyond 40 centimeters and you are not able to feel resistance, remember you are entering to the esophagus. The other last thing which I am going to tell is endotracheal tube introducer with stilette. So now in the video laryngoscopy era, I personally feel Bougies are not so important because this hyperangulated blades, when you are using hyperangulated blades, it is very difficult to manipulate the Bougie to enter into the vocal cords, because we are not going to do the neck movements to align the axis. So hyperangulated blades means Bougie will be of difficult choice. So we are preferring stillets. The peculiarity of the stillet is the tip is very soft. Inside it contains a metal, small metal rod, but then the tip of the Bougie is going to be short to prevent trauma. So this is the ideal placement of stillet for a endotracheal tube. Depending on the patient, if you feel the hyperangulation is needed, you can bend some more. So the ideal position is like this. You are supposed to introduce the stillet. The tip of the stillet should be at the level of the bevel, and it should be like a hockey shape. The last thing I'm going to tell is one of the very valuable devices, entry airway exchanges. So these are all very important devices compared to, even sometimes we can use this Bougies for replacement. But the peculiarity of the device is it is of wider diameter and it is a hollow tube. You can see multiple openings. So when you are not able to re-intubate, you can ventilate through this. So that is one of the biggest advantage. The second advantage is the diameter of the entry. See, remember a situation like you are intubating through fiber optic bronchoscope or intubating through a supraglottic devices where it is a conduit. So when you intubate over a fiber optic bronchoscope, suppose you are intubating adult patient with 4.5 mm fiber optic bronchoscope and you are using 7 mm internal diameter tube. The space between the outer sheath of the fiber optic bronchoscope and the internal diameter tube is going to be very high. So especially at the level of vocal cord, it is going to create a trouble because a lot of soft tissues like arytenoids get caught in between the tube and the bronchoscope. So there is high chance that the tube might not be able to pass inside with ease. But at the same time, if you are going to use entry catheter, it is going to provide a good diameter and you are going to railroad the endotracheal tube. The space between the entry catheter and endotracheal tube is going to be very less and there is no much play or space for play. So we can easily railroad the tube without much difficulty. At the same time, it can be used for exchange of tubes. Like suppose we didn't plan for IC ventilation for a OMFS procedure, we have intubated with a array tube or flexor tube. Those are not good choice for post-operative ventilation. In such situations where the chance when we extubate and re-intubate, the chance of failed intubation is high, we can use this wonderful device. So with this, we come to the conclusion. So my take-home point is, whatever be the available gadgets, please understand the physics behind that, so that each and every part of the tube, if you understand why it is devised, you can have a maximum utilization of this device. So in some more, since we don't have much time, we have not discussed about laryngoscopy and fiber optic bronchoscope, but I hope I have enumerated few salient points. Thank you very much, sir.
Thank you, Dr. Senthil. Can you hear me, Dr. Senthil?
Voice is low, sir.
Sir, Edward, sir, I'm not able to hear whatever.
Rajesh, sir, your voice is very low.
You're not able to hear anything, sir. Actually.
Okay, I will take the questions.
Sure, sir.
Sir, how to decide the pediatric tube size?
Sir, sir, actually, we commonly follow the formula of whether the patient's age is 6 years or above. So less than 6 years, we use the age by 3 plus 3.5 formula, or more than that, age by 4 plus 4.5 formula. And when there are multiple formulas, sir. Personally, what I feel is, out of my experience, I will have, based on formula, I will decide the tube, and I will try to make a tube 1 or 0.5 above and 0.5 below, so that the chance of reintubation is very less. And nowadays, since we have started using microcuff tube, the reintubation rate is definitely less. So it's like uncuffed tube. So, and in our institute, we have used in some study, we did a study where we used preoperative ultrasonography to measure the diameter of airway. If facilities are available, that only is going to help us more. With that study, we came to a conclusion that the chance of reintubation is very, very less. So nowadays, they're using cuffed endotracheal tubes to avoid the discrepancy.
So the questions are from postgraduate, so it will be the basic level.
Yes, so
what is the difference between the regular and flexometallic?
Difference between
the regular tube and flexometallic?
Flexometallic tube is actually, the basic difference is it is completely wire reinforced except at the level of connector and the Murphy side. So this is supposed to be kink resistant. So whenever we are using it for head and neck surgeries where there is much manipulation of airway is going to be there, to avoid the kink or to increase the resistance, we are going to use this reinforced tube. So the most important thing is when you are using flexor tube, unlike cortex tube, you should be intubating with a stilette. The stilette becomes mandatory.
So the same question is, what is the special points about the microlaryngeal tube? Is it available in all sizes?
Yes, sir. It's available. See, what I have seen is it's available in 5, 5.5 and 6 size tubes. So basically, according to anesthesiologist, what we prefer to put larger size tube. But the surgeons usually always ask smaller size tube. So what we decide in our institute is we will try to get a good orientation. That is, we try to get a video laryngoscopy picture where exactly where the lesion is located. If it is in the anterior part of vocal cord, we try to put smaller size tube. If it is in the posterior part, we try to put larger size tube because that provides a lot of difference. So since tube is going to lie on the anterior aspect, posterior size tube, posterior side lesions, in such situations, we will prefer a smaller size tube.
Okay, sir. So how long the flexor metallic tube can be kept in the postoperative period before changing to PVC tube?
Sir, ideally speaking, we should have a thorough discussion with the surgery team during the procedure. So it's not recommended to keep it in the postoperative ideally, because it is definitely going to keep increase resistance. Literatures, I exactly don't know, but in our institute, for one day, if accidentally we place and suddenly we are not able to intubate, we usually keep up for up to 24 to 48 hours.
Okay, sir. Thank you very much, sir.
Thank you very much.
There are the questions available. We can move to the second topic.
Thank you, sir.
Thank you, sir. So the second topic is Supraglottic Airways by Dr. Ramkumar. So he is also an assistant professor from SRMC, Chennai, and famous among the.
I hope you can see my screen. I'm audible enough.
Okay. You are audible, sir. You can start your presentations.
Yes, sir. You can see my screen, right?
Yes, sir. It's audible. We can see.
Yeah.
It's audible also.
Yeah. Thank you so much. Good morning, everyone. The topic given to me is supraglottic airway device. I'm Dr. Ramkumar. I'm associate professor in SRMC, Chennai. The objective of my talk is to cover the supraglottic device in the following headings, like initially about the history and the classification and the important features in the current second generation devices. And we're going to revisit some of the old devices and the current new devices, the important safety features and the common standard insertion techniques and device specific insertion techniques. And if that goes wrong, if there is a device failure, we'll see what are the rescue maneuvers to be done to have a very good ventilation. And finally, we'll see some of the important advanced applications, not all. And finally, the take-home points, which that is almost mandatory for your exam purpose as well as for your practice. To begin with the history, the supraglottic device, the LMA was the first one. This is a laryngeal mask airway. That's a trademark device. In exams, you can't use laryngeal mask airway as a terminology because it's a trademark name taken by the laryngeal mask company. So LMA was the first device developed by Dr. Rajesh Brain in 1981, but it came to practice in 1988 in UK and probably in 1991 in US, and flow on and further on. That's like we've got many other devices. So what Rajesh Brain has said that it's an alternative device either between the endotracheal tube or the face mask ventilation for both spontaneous and the passive pressure ventilation. Initially, it was devised for a superficial surgeries or a rescue ventilation. Then later on, it has gone to many other advanced applications. And from then, we got LMA ProSeal, LMA Supreme, intubating laryngeal mask airway. Then we got many other devices. So how to classify these devices and monitoring? So far, there is no universally agreed nomenclature, definition, or a terminology, classification. The current terminology which tends to relate with the supraglottic airway devices is supraglottic airway, that is supraglottic airway devices, or a SGA, supraglottic airways. Another terminology that's linked the practice is extraglottic airway devices or extraglottic airways. So see what is supraglottic airway device. Supraglottic device is a device which you commonly tend to use in a practice. All these devices have a mask with a ventilation orifice which is present just above the glottis. Whereas extraglottic airways, Senthil sir talked about the Combitubes and other easy tube. That devices have got an extension, the tube which is extending into the upper airway area as well. That is, the tube has got extension below the glottis, but the ventilation happens between the hypopharynx and the glottis. So all these devices are termed and the thing called extraglottic airway devices. But what we are going to see is about the supraglottic airway. What is the current classification which is very practical or is morally accepted is that Tim Cook's classification. Before that, we had classification which is based upon the anatomico-mechanistic facility of each device. It was Miller who classified as an cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and cuffless anatomical pre-shaped sealers. Later on in 2012, when all this extraglottic airways comes into the play, that means this device does not violate into a glottis and the ventilation orifice is just in and around the bedglottic area. So it is classified as extraglottic airway device with an inflatable periglottic cuff like an ambu or LMM mask airway, or an extraglottic airways with no inflatable cuff like IGL and SLIPA. Then other classifications, extraglottic airways with two inflatable cuffs like Combitube and easy tube. And the other one is like extraglottic airways with a single pharyngeal inflatable cuff like Cobra PLA. What the recent classification, which was like given by Tim Cook in 2009, is said it's better to use it as a first generation device and a second generation device, which is more practical, and that's why it is called as a pragmatic classification. The first generation device are like seen as a simple airway tubes, just for a ventilation purpose is used, but no other advantages. Whereas the second generation device has got features to reduce the risk of pulmonary aspirations, so thereby preventing a lot of complications. There are n number of first generation devices which are like slowly going out of the practice. Currently in Indian center, we tend to use LMA Classic or LMA Unique, Ambu, LMA just LMA Flexible or Ambu again. But the second generation device, we have got only few like LMA ProSeal, LMA Supri, laryngeal, LMA Protector, Ambu or again or a Basca mask or a RQ blocker. What is the first generation device? Why it is not like slowly going out of the practice? It is considered as a simple airway tube, just an airway tube with this, which has got a connector and the airway connector, which is 50mm connector at the top, and a mask, which is silicone or a PVC size mask in a disposable type with an epiglottic aperture bars. This is epiglottic aperture bar, which is there to prevent epiglottic obstructing the ventilation. So this device has got a poor or a low oropharyngeal leak pressure. What is oropharyngeal leak pressure? It is a pressure above which the ventilation, the tube tends to leak. That means the gas is going to, ventilating gas is going to escape into the esophagus, into stomach, or escape upwards. That means there is going to be hypoventilation, displacement of device if you're trying to ventilate with a higher airway pressure, say a patient with the obese or a laparoscopy surgery or an pregnant patient is going to displace backwards and upwards. So it may cause hypoventilation and same time has got an aspiration risk. And apart from that, it has gotten cuff-related injuries as well. If you tend to inflate with higher cuff pressure, it can cause mucosal injuries. That's why what I think is it's time to abandon this vintage laryngeal mask and it's time to start using second generation device. What is the advantage of this using second generation device? The main purpose is better ventilation, because all these devices got a better oropharyngeal leak pressure, which is around 30 centimeters of water. And at the same time, it has got drain tubes, so it can aspirate the gastric contents. And the seal, the esophageal seal, that is the tip of the mask, which rests on the upper esophageal sphincter. It forms a bulk space here. It causes mechanical obstruction of gastric contents. And the facility of gastric tube, which is going where we can pass an nasogastric tube and aspirate the gastric contents, you can reduce the chance of aspiration. And the mask seal, which is like double seal, a double cuff with a pro seal, or a soft gel-like cuff with an iGel, or any other device which has got a very good seal around the periglottic structure. That is called pharyngeal seal or a gas seal. That's a oropharyngeal seal, which gives hypopharyngeal seal, which gives a very good ventilation. So this is a main advantage of second generation device. That's why everyone suggests to use a second generation device. But currently, in recent times, there are like articles saying that Basca mask as a third generation device. why it is tend to like place it on third generation device? Because of the self-energizing sealing mechanism. This has got a silicon semi-membranous cuff, which is open cuff, which tends to get a seal with an higher oropharyngeal leak pressure or higher airway pressure. I'll just demonstrate how this cuff works. See, when you tend to ventilate, you can observe here, the cuff tends to move anteriorly, that is like upwards. That means that as the airway pressure increases, the seal increases. The seal within glottis or periglottic structure increases. Whereas with other devices, when the airway pressure increases beyond their like 30 centimeter of water or appropriate for that particular device, there's a chance of leak. So here the Vasca mask, as the airway pressure increases, seal increases. But what Tim proposed that, but this advantage of Vasca mask is not like proven by evidences. So there's lack of evidence on this. So what he said is the classification as first and second generation is retained, and Vasca mask still same in the second generation device, and he suggested a couple of suffixes. He said that a second generation device with the suffix of I is meant for a device which has got an intubation success rate more than 50%, and if the suffix D is used, that is for a direct intubation. If suffix G is used, that is for a guided intubation. Coming to what are the desired features of a supraglottic device. When I choose a supraglottic device, the two essential requirement of a device is to have a reliable sealing without obstruction. And next is the important one, it should prevent aspiration. The preferential requirement is to access to the airway. That is, it can be used to intubate, or it can be used as a conduit to endotracheal intubation. What are the features which helps to get this features, very useful. Coming to the design features, the drain tube, as I already said, drain tube is with the drain tube we can reduce the risk of aspiration and reduce the risk of gastric insufflation. And next is the bite block. If the patient is like an inadequate pain, they tended to bite the supraglottic device, so they can go for an obstruction and they go for an hypoventilation or hypoxia. So the bite block, if it's a rigid material which is present at the upper end of the device, as shown here. This is a bite block here, and there's a bite block here, which is around the teeth area. They prevent the occlusion of the supraglottic device when the patient is in inadequate plane. And there's a fixation tab with a LMA protector or a LMA supreme, which helps you to guide where the device is placed, whether it's placed appropriately or not. And with this tab, we can place the plaster to secure the device in a proper position. And the availability of the reusable or a single-use device, all these devices helps to get a better seal. Whereas in the Pro Seal, it's got double cuff, which is silicon cuff, whereas this is LMA fast, a disposable version of an ILMA. These designs help us to improve the efficacy of these devices. This efficacy is assessed based upon the insertion success rate, and the main part is the first attempt success rate. If you are planning to do a thesis or a study on a supraglottic device, the other important parameter is to assess the success rate of the first attempt. A device which has got a success rate more than 90%, that means that it's got a very good success rate. At the same time, it should cause any trauma. So the less trauma is also very important with the device. So that is also should be considered. And next important thing is the patency. How the airway patency is maintained, and the ventilation parameter. The important parameter is to assess the oropharyngeal seal. That is, you assess the oropharyngeal leak pressure. That is done by the few performance tests, which I'm going to show you later in subsequent slides. It's a oropharyngeal leak pressure or a minute ventilation test. Another is how can you access to the airway. So that is the chance of intubation through a device. All these decides helps to assess the efficacy of a particular supraglottic device. Let's see what is oropharyngeal leak pressure. That is important because when doing a study or when you're going to use a device for a obese patient or a laparoscopy surgery, we need to know the oropharyngeal leak pressure because you don't want a leak or hypoventilation in the middle of a surgery. What it is to design and find out what is the OLP. Oropharyngeal leak pressure is to determine the maximum airway pressure achievable before the gas leaks. Above which, if above the pressure, there is going to be impairment of ventilation, gastric insufflation, and aspiration. How it is tested? The definition is, this is how it's done. I'm showing an assessment of oropharyngeal leak pressure in the middle of a laparoscopic surgery, because if it's going to leak in the middle of the surgery, then it's going to be difficult to intubate or manage the patient. Here I'm using a Pro Seal. 3 liters of flow is kept. I'm closing the apial valve to 30 centimeter of water. and I'm going for a apneic period, that is a manual ventilation, leaving the system like that. So as the 3 liters of gas flows, there's going to be a rise in airway pressure, which is going to having a upslope here. So at one point, it is going to reach the plateau. See, can you see the plateau at the 30 centimeter? If at one point it reaches the plateau, or it's going to leak. When you hear audible leak, or you achieve an equilibrium with the system, that is at 30 centimeter of water, that is the oropharyngeal leak pressure of the particular device. Here, the oropharyngeal leak pressure of this particular device as a ProSeal is around 30 centimeter of water. This is how it tested, and this is the way you should use it. This is a like definition kind that should be used in your practice or in your study. And coming to other performance tests is the maximum minute ventilation test. This is to determine what is the actual maximum minute ventilation, because if there is a leak or a slow expiratory flow, that is going to affect this maximum minute ventilation which is achieved for the patient. How to do this test? You close the APLO at 30 centimeter of water, then what you do is like do a maximum ventilation, like increase the ventilation for 15 seconds. And if you're able to see that maximum ventilation is greater than 2 liters per minute, that means that your supraglottic airway function is SGA functions very well. These are 2 tests to identify the ventilation parameter of a particular device. Coming to the safety aspect of a ventilation device, the important aspect is about aspiration protection. What the risk aspiration with a supraglottic device, the average is around 1:4,000 to 1:12,000 in elective cases. In comparison to a endotracheal tube, it is around 1:4,000. In emergency situation, the risk aspiration is 1 in 1,000 with SGA. With endotracheal tube is 1 in 900. The aspiration is like far less nowadays because of the features like drain tube, as already told, and because the bulky tip, which prevents mechanically occludes the upper esophageal sphincter, so prevents or like minimizes the risk of aspiration into the risk of decongestion into the throat. And the Basca mask has a sump in the posterior aspect, which tends to collect the gastric contents, and that can be aspirated through the drain tube, which is present on either side of the ventilating tube, which I'm going to show in later slides. So next is like the traumatic placement. If there is going to be a traumatic placement or a difficult insertion, there are going to be complications. The minor complication will be a sore throat. If the device placed there for a longer period of the cuff is inflated and is more than 60 centimeters of water, chance of mucosal injury is also high, the chance of dysphonia and dysphagia. And if it's going to be a difficult placement or a difficult prolonged usage and the prolonged high pressure cuff is there, then the chance of arytenoid dislocation, tongue enlargement and cyanosis can occur, and the chance of lingual, recurrent laryngeal or hypoglossal nerve injury can occur. This things to be kept in mind. So to prevent this, you have to choose an appropriate device for a particular age, particular gender, and a particular weight of a patient, and use an appropriate techniques in a very good plane of anesthesia. And the position of device as well as the position of head and neck position is also very important to avoid such injuries. And make sure if you're using a cuff device, make sure the cuff pressure is less than 16 centimeters of water. And nowadays we've got a silicon-based cuff and a soft gel like a thermoplastic elastomer and eye gel. All this reduces the risk of mucosal injury, thereby future problems. And try to avoid the prolonged use of supraglottic devices because that can easily end up in sore throat and mucosal injury. From now on, like we're going to see some of the important features, the safety features or unique features of the available common devices in our part of country. The devices which you're going to see are ProSeal, LMA Supreme, iGel, Basca mask and Basca Vest mask, Ambora Gain and ILMA and LMA Protector. First is the ProSeal got 2 tubes. One is the airway tube, the anterior, this is the anterior cuff, this is the posterior or dorsal cuff. And next is the drain tube, which is there, which runs in the posterior aspect of the posterior part of the bowl, that's the cuff bowl, and ends up on the tip of the mask. This tube, which is there in the posterior part, prevents the epiglottic obstruction, the epiglottic blocking the ventilation. It is almost equivalent to epiglottic aperture bar or a epiglottic elevating bar in the other devices. The problem with the ProSeal is that the cup is made up of silicone, which is very soft, which can cause backfolding or it can enter into the glottis if you insert without beyond the maximum resistance. That can cause obstruction. Other thing is the cup can get distorted with the multiple use and can herniate and can cause displacement while placing it. reusable device. If you're trying to use more than 40 times and there's a chance of wear and tear, the mucosal cuff damage can occur. All this can lead to a poor ventilation, and chance of displacement is very high. The success rate with this device is around close to 90% at the first attempt, but the success rate improves to 100% with the 3 attempts. And with the Bougie guided technique, even the first attempt success rate is 100%. That's a pure, it's 100% correct placement. The oropharyngeal leak pressure for ProSeal is around 27 to 31, which is like almost highest of the available devices in our kind of part. And coming to LMA Supreme is like a combination of 3 devices. It is disposable like LMA Unique. It has got a rigid curved shaft like an intubating laryngeal mask airway, that is ILMA, and is like a normal oropharyngeal curvature, so doesn't require a sniffing position to insert it, and it has got a gastric access as a ProSeal. So it combines features of 3 other LMA devices. The advantage is it's got a narrow mask, so easy to insert in a lesser small. It's normally require a 2-finger mouth, 2-centimeter mouth opening to insert a laryngeal mask airway. This has got little advantage to place it. And it has got 2 lateral grooves on either side of the tube, which prevents airway tube kinking as well. The issues or limitations are here. It is made up of PVC, so there's more chance of trauma when compared to silicone devices. And the problem is the drain tube runs in the middle of a ventilation airway lumen. So we cannot do, it's difficult to do a blind intubation. So what you can do is you can do a pediatric fibrotic bronchoscopy and pass a guide wire, and you could do a guided intubation if at all you want to intubate through a LMA Supreme, and still the chance of cuff-related complications can be there if you use for prolonged period for a high cuff pressure. The success rate is around 90% with the first attempt. It's 100% around the third attempt. The leak pressure is around 26 to 30 centimeter of water with LMA Supreme. Coming to other important devices, the important innovation is the iGel. iGel is a preformed second generation device invented by Mohammad Nazir, who is from UK, is a Pakistani. It is an excellent device because it is a cuffless mask. It is made up of a gel, and it has got an airway tube with a bite block in it, and a airway tube with the upper end can be connected. It is a 50mm connector, and bite block and the buccal cavity stabilizer. So this airway tube is not cylindrical with other LMA devices. It is an horizontally overt or elliptical in surface. So it fixes or stabilizes stuff in the oral and the throat easily, and the chance of displacement is very less. And there is a small projection in the cuff. It's called epiglottic rest, which prevents the epiglottis obstructing your ventilation. And as I said, this is the tip of the device where the drain tube, the nasogastric tube comes through out of it, and the entrance is at the upper end on the right side of the ventilating lumen. The important feature is this mask, this cuff, which is made up of a thermoplastic elastomer. The chemical name is styrene, ethylene, butadiene, and styrene. This is it's not like uniform in shape. It has got some elevations and depressions and notches, which is exactly the mirror image of this periglottic structure. So it fits very well as it's inserted with the body temperature. It adapts to it fits to the periglottic structure very well. So it gives very good ventilation and very good oropharyngeal leak pressure is very high. So chance of displacement is very less, and chance of aspiration also is less because of the availability of drain tube. Because of this material, they say that it's very stable in high altitudes and hyperbaric conditions. So this is the device which can be used in helicopter transfers as well. The success rate is close to 90% of the first attempt, and it's 100% at third attempt. The average leak pressure is around 26 to 30 centimeter of water. Vasca mask, and Vasca mask is a silicone device. It's a disposable silicone device. Still is considered a second generation device. The important aspect is the self-energizing sealing mechanism, and the posterior aspect is the sump aspect. It is connected to the tip, so all the gastric contents can be collected and aspirated on either side of the drain tubes. The oropharyngeal leak pressure, what it is studied, and it is the manufacturer's claims is around 40 centimeter of water. The features here are, it has got a tab, which pulling the tab, it can be made into a preformed like an normal anatomical curvature like an ILMA. So it can be used, inserted without a sniffing position. That is, if a patient has got a C-spine fracture or a difficult neck extension, then this can be used to insert it. So that's advantage of this in Vasca mask. And the mask is an open cuff system. It is a semi-membranous silicone cuff. which gives a very good sealing. As I already told, as the air pressure increases, the seal increases. And really, that's a sump. This sump and the airway cavity is like separated. They are not interconnected. And the sump is distally connected to the. Next is the suction elbow on the drain tubes, which are there on either side of ventilating lumen. This is the ventilating lumen. You can see the ventilating lumen. On either side is a sump, and there's a suction elbow that can be attached to either side to attach to a direct wall mount suctioning. So you can have high negative pressure suctioning as well. As I said, this is the which is distally connected to the mask, which has got a projection which enters into the upper esophagus, so it snugly fits into it. So the chance of aspiration is like reduced. All the gassy contents which is there, irregular handle with a preformed rigid curved shaft, which is almost like there's a leak. What you have to do is hold the handle, manipulate the handle in horizontal and sagittal planes. This is a sagittal movement and horizontal movement. So that at the same time, you got to start ventilating it with the cuff inflated position. When you start moving in a sagittal movement or a little horizontal, at one point you will get a very good ventilation with the least resistance or least tension in your ventilating bag with a very good rectangular trace in your ETCO2. That means that that's the best place to place the device. And once it's placed, you should not change the movement. You cannot move the device, and that's a place to ventilate, and that's the best position to intubate as well. So this is called Chandis manner part 1. What is Chandis manner part 2? Chandis manner part 2 is done during intubation, during passing endotracheal tube. Once the tube is like inserted till the epiglottic elevating bar, I think hope you'll understand what is like a epiglottic elevating bar at particular point. So there's a black mark. There'll be a black mark directly into the laryngeal inlet, instead of going to hitting the epiglottis or into the esophagus. This is called Chandis manner part 2. That is lifting the handle anteriorly to guide the intubation. What is the advantage of having ILMA? ILMA is that it can insert in the neutral position, so that can be used in a C-spine injury or a restricted neck movement patient. And it is a device of choice previously and still now, because you can, if you're not able to intubate in an unanticipated, like a difficult intubation, you can insert it, you can oxygenate the patient, and if required, you can use as a conduit to intubate the patient. The limitations are there are no pediatric size available. It's available in sizes 3, 4, 5, and it has got no protection against aspiration. So that's the issue, and it's a reusable device. Chance of infection is still high, and it's quite costly as well. It's around 40,000 bucks. So the advantage of the use of ILMA. Now going to a recently introduced device called LMA Protector. The advantage here is it's a single-use device which is available in silicon. It has got 2 drain tube. One is projected and one is there to pass an rails tube. You can understand, see here. One you can just do attach a suction catheter and do a suctioning, and it has got a pilot, which is cup pilot technology. It has got color markings to indicate the pressure. It ideally should be in the, if cuff is inflated, it should be in the range of green color, that is around 40 to 60 centimeter of water. If it goes to red area, that means it is gone, air pressure, cuff pressure has gone beyond 70 centimeter. That means you have to deflate, especially when you start using nitrous oxide, you have to frequently assess this. That's the advantage of using this device, which has got a very good cup pilot technology. Coming to, after seeing all these devices, let's troubleshoot the problems. The common dilemmas of using a supraglottic device is the leak or hypoventilation, and next thing is an obstruction, where there's like not able to ventilate, there's an high air pressure is there, ventilation is like almost nil or reduced. The common advice is to, anywhere the problem you're not able to ventilate, if there's a leak, the problem is the adequacy of plane. If the plane is inadequate, the vocal rod tends to move, it will not allow us to ventilate properly, or it may end up in laryngospasm. Other problem is the pharyngeal muscles still can contract, so they can displace the device away from the glottis, and that's the issue with the inserting a supraglottic device in an inadequate plane. So deepen the plane of anesthesia, especially with the intravenous anesthetics. Make sure the cuff pressure is within 60 centimeter of water. If the cuff pressure is more than high, the cuff can like enlarge or swell and can cause displacement. And if nothing works, you remove and reinsert a next possible or higher or a smaller device, or you can do maneuvers, which I'm going to show now. And if at all nothing works, then you have to place it as you can call it as a failed SGA. So what is the definition of a failed SGA? If you are not able to achieve a tidal volume of less than, if at least 6 ml per kg. That is the tidal volume is around 6 ml per kg. That is persistent, and there's a progressive rise in EtCO2, and the SpO2 is less than 90%. And despite doing maneuvers and size adjustments, there is persistent leak or an upper air obstruction. That means the device is failed. You have to switch over to other best possible device or an switch over to endotracheal tube. Depends upon the necessity of the surgery or a resuscitation. Coming to how will you know that the device is failed? You need to know what are the ways to test the correct placement. Important thing is when you're able to pass an nasogastric tube into the stomach and you can aspirate, and that means that your tip of the mask is in the upper nasal sphincter. That means that the cuff, the ventilation orifice of the cuff is in line with the laryngeal inlet. So that means that shows your placement is almost correct. Or you can perform a oropharyngeal leak pressure test, which is up near to the advice or manufacturer's number. That means you can get a very good ventilation with the device. So that shows that your placement is right. If at all, if you are available, you have a fibrotic device and the patient requires an endotracheal intubation, you can view the orifice, view the placement of vocal cord by passing the fibrotic scope through the airway channel. And you can watch EtCO2 trace. These are auxiliary guidelines. You can auscultate for ventilation for any wheezes or obstruction or laryngospasm. Bronchospasms. And next thing is you can view the position of the external part of the device, whether there's a marking which is close to the incisor or away from the incisor. These are the guides to know whether the device is properly placed or not. There are a couple of tests which is more regard to ProSeal, which can help you to know whether it's placed properly or not. This is called a supracell notch test or a gel displacement test, where you can place a gel on the drain tube or a soap bubble, and what you have to do is and look for this movement of gel. There should be a slow movement like a meniscal when you press the supracennal notch. That means you're pressing the trachea, that in turn pressurizes or compresses the esophagus. That is, if the esophagus and the tip of the drain tube is in line, the pressure is transmitted to the drain tube, and that is seen as a small movement. If there is no movement, that means the mask is too high or the cuff is folded back. Here, the gel displacement test is done with the ventilation. You just continue to ventilate. Along with the ventilation, this device has to, the gel has to move up and down like a meniscal. If it is not moving or it is popped off, that means your device is not placed in, it's too high or into the glottis. This is one of the tests to identify the correct placement of the supraglottic ProSeal. Next is these are the tests. Based on this test, you can identify whether the placement of your devices are correct or perfect. Next, we'll move on to insertion techniques. The standard insertion technique for a device as prescribed by Archie-Brain is the digital insertion technique. This I would like to demonstrate with the ProSeal. So you should be in a sniffing position. Patient preparation should be in an adequate plane. You should have adequate mouth opening, at least 2 centimeters of mouth opening should be there to pass on the device. And the device should be pre-use check should be done. They should be checked for a leak. And there shouldn't be an obstruction because with clots or anything, because it's a reusable device. The device is held in the insertion tab place and it is inserted along the palate. The idea is to, so this is the movement. You should get a hyperextension at the interphalangeal joint. I'll show you once. You place a finger at the place where the metal handle can be fixed or your finger can be fixed, and the LMA is, the ProSeal LMA is holding the device, mouth open is achieved. Sniffing position is important, mandatory for this. To take the mask along the palate, not anteriorly, because once you go anteriorly, you can tend to drag the tongue. And once you place your fingers, the movement is like your interphalangeal joints is extended and the wrist is flexed. So you guide till you get a resistance. If a finger length is short, you can use your non-dominant hand to place it till you get resistance. And that's a way to do a digital insertion technique. Coming to a bougie carrier technique, which gives a 100% success rate. See, I'm passing a bougie into the esophagus. That's a vocal cord. Is a esophageal opening. I'm placing that. Insert the bougie into the esophagus and railroad the LMA through the drain through the drain tube. And that is done till you get resistance. So this gives a success rate which is close to 100%. The aim is to place the tip of the cuff at the upper esophageal sphincter. So that gives a very good placement and success rate is quite 100%. Coming to other device, Bhaskar mask insertion is quite different. Here the device is like lubricated on either surface with a water-based jelly, and the lip is also lubricated. The device is quite bulky, but this is how it's inserted. You get a very good sniffing position, just inserted because it's a soft silicone tube. If it smoothly squeezes itself into the hypopharynx, so it doesn't require any distal manual mouth opening or a distal insertion technique. So we can insert it within like a few seconds, less than 10 seconds. And the advantage is you can use this drain, suction elbow on either side, you can pass a, so I'm suctioning the drain tube. This is the only device where I can do a hypopharyngeal suction as well as a gastric suction, and you can pass the Ryle's tube, already pass the Ryle's tube into it. That's the advantage of the device. There's a Ryle's tube on the other side, and this is kept as a vent. You cannot do a suctioning on both sides. One has to be kept as a vent to avoid mucosal injury. Coming to other like maneuvers where you tend to have resistance or difficulty in placing, especially with an IGL, in an obese short neck patient who has got a OSA or a large tongue. In such cases, tongue also tends to move along with the device and it goes to the pharynx, falls on the pharynx and prevents or obstructs the placement of a device. The one technique is like Suzuki mentioned for IGL, it's called a jaw thrust technique. What you do is you pass the mask cuff into the mouth and you do a jaw thrust maneuver and simultaneously insert the tube inside. This is called jaw thrust technique, where you expand the pharyngeal space and prevent the tongue falling back. So the device placement is quite successful. Other technique is the tongue retraction technique. Again, this is best for preform shaped devices like IGL, where a tongue doesn't allow the placement of a device. What I do is like with my thumb, or you can use one blade alone, in the laryngoscope blade alone, you retract the tongue away from the palate and you can pass the tube. So it gives a very good insertion and success rate is quite high. And the other maneuver is called clean maneuver. It was initially describes to RQLMA, but can be applied to any other device where, again, I said like where there's an OSA patient or epiglottis downfall is suspected, or where the patient has got an upper air obstruction, which you can identify during a mask ventilation. What you have to do is ask your assistant to do a jaw thrust. A jaw thrust is done and mask is inserted. With the mask, with cuff inflated, with the bag ventilation, you just remove the device 4 centimeters upwards and reinsert it. At one point, you are able to get a very good ventilation with the least resistance. That's the best place to keep it. So the ventilation is good. If you want, that's the best place to intubate as well. If you're at all, you don't have fiber optic bronchoscope to guide your intubation. This is called Cleance maneuver. That is called a use of jaw thrust with an up and down maneuver. Coming to other technique which has been reported, it's called awake insertion technique. I thought instead of trying on a patient, I thought I'll try on myself. On right side, I'm using a 4-size Bhaskar mask. On left side, it's an ambu or a gain inserted. And this is LMA Supreme, where I added 2 puffs of 10% Xylacane spray. After that, I could manually insert it. The insertion technique doesn't, no need to insert your finger, keep your fingers, insert the fingers distally, just pass on along the palate. In all 3 devices, I could get a very good ventilation. Very good spontaneous ventilation. So I thought instead of trying on a patient, I thought do a awake insertion of myself, able to pass on, we get a very good spontaneous ventilation through it. And with this device, I'm able to pass an nasogastric tube also. That doesn't mean that you have to try always. This can be helpful if you don't have anything, if it's a patient has a difficult airway. And finally, coming to the advanced applications of a devices. The basic applications are use of Supra devices to use for a superficial peripheral surgeries, or in situations where you're not able to be there in the end, and such cases it can be used the basic uses. But we'll see what are the advanced uses. It can be used as a conduit to intubate. It can be used as a rescue device during LSCS. It can be used as a rescue device in a prone surgery. It can be used in laparoscopy surgeries, pediatric surgeries, and nasal surgeries. We'll see the use as conduit to intubate. Once you inserted, ventilation is good. You can do a one-step blind intubation, which nobody else is going to suggest it, because those success around 90%. If there is use of tricot pressure, the success rate drops to 56%. And other technique is the two-step Bougie technique. Instead of passing a preloaded, passing an endotracheal blindly, what I can do is once a supraglottic device is placed, pass the Bougie into it. Once the Bougie passes the epiglottis, remove the supraglottic device and intubate blindly. This is not at all advised because of the trauma which can be caused and which may end up in cannot intubate or cannot ventilate scenario. What is advised is to use a fiber optic aided intubation. It can be like it can have 3 types. That is already a preloaded endotracheal tube through a insertion cord of a fiber optic device. That is called one-step fiber optic aided intubation. If that otherwise, you can use a 2-step fiber optic aided intubation. If the tube size is more than 7 or 8, there is going to be a play between the endotracheal tube and the insertion cord. So the tube may get caught into a arytenoid and it will not be placed. Though you can visualize the glottis, the intubation is going to be blind. So it can cause injury to arytenoids and other pericardial structure. So what you can do is you can use an entry catheter. Entry catheter is loaded into fiber optic scope. The entry catheter is inserted in the vocal cord. Then the fiber optic scope is removed, the LMA is removed, and the supraglottic device is removed, and the intubation is done. Or you can do a 3-step fiber optic guided intubation. One is like pass a fiber optic scope first, pass a guide wire through the working channel, remove the fiber optic, pass an airway extension catheter through the guide wire, and after removal of FOB, then you can intubate through the airway extension catheter. This also sounds good when you are not able to pass a tube through a fiber optic scope into a trachea. So these are the ways to intubate through a supraglottic device. Here I can do a single-step fiber optic intubation. The first one is like I can visualize my own glottis. That means the placement is perfect. Another technique is like I'm trying to intubate. I add like 4% like a nebulization and place the Ambu device into my hypopharynx, and my colleague is able to visualize the glottis, then the carina. Finally, is able to pass on the tube. The tube is able to pass, and I could see my own carina. This is still possible in a difficult airway scenario where you don't want to anesthetize and get into clot. Coming to use of supraglottic device in LSCS, there is a meta-analysis saying that you can establish airway rapidly with ProSeal LMA because it's got a gastric drainage. There are a lot of studies coming up. The advice is to keep it as a rescue device in a difficult airway, and same thing you can intubate through the device, second generation device, anything. If it is going to be a rescue device when you're not able to intubate, and the ideal choice will be a second generation device which has got a very good high oropharyngeal leak pressure, and then a drain tube can be passed and you can reduce the chance of aspiration. The ideal scenario would be a non-obese, preferably a fasted patient and relative cases. And the other important advice is ask surgeon not to give excessive fundal pressure because it can cause dislodgement of device as well as chance of regurgitation aspiration is very high. Coming to the use of supraglottic device in a prone position, while doing a study or research on it, I found an Indian article saying that where ProSeal used, where the ProSeal LMA induction is done in a prone position, they wanted to show that it required fewer personal insert theater and reduce the surgical readiness. But for me, I wanted to show that if in case endotracheal tube displaces in a prone position, we shouldn't be like go mad. You can always mask ventilate, or you can insert a supraglottic device in a prone position, oxygenate. The motto is to oxygenate, not to turn the patient, cover the surgical area, turn it, get the trolley inside, turn the patient, then try to intubate. That is not the goal. So we can mask ventilate or do a supraglottic insertion in the prone position itself. So I wanted to show this as an like a conference booster. Say here what I did is like the advantage is I can ask the patient to lie prone on their own way so that they can avoid chest and abdominal compressions. Once the device is inserted, then you can use muscle relaxant. And you always keep the trolley alongside so that anything goes wrong, you can always turn the patient into the trolley supine, then you can intubate. Here the ProSeal LMA is inserted with almost like neck extension position in the prone position. And this is surgery on a heel going on with the ProSeal inserted. And always advise you to use the Ryle's tube through the gastric channel, because whenever there is a displacement of this device away from the mouth, you can railroad the device through the Ryle's tube again to place it to a in the periglottic area, and you can continue ventilation. So that's the advantage of using the Riles tube in this cases, and as well as you can reduce the chance of aspiration. Again, this works very good in the hands of experienced anesthesiologists. Coming to the use of supra device in laparoscopy surgeries, again it's studied well. There are a lot of studies and meta-analysis done. It says that it's clinically more useful, as effective as an effective airway in laparoscopy surgery. The problem here is when a laparoscopy surgery, especially in obese patient, you need a lot of high peak ventilation pressures. So if to ventilate such patients against the diaphragm which is pushed up, and so that you need to open up the airway or ventilate with an higher pressure. If during the process, the oropharyngeal leak pressure is very high, very less for a particular supraglottic device, there's a chance of hypoventilation, gastric insufflation, reconstitutions can occur. So that is a problem with any supraglottic device, and that occurs, that is more unfavorable in obese head-low surgery, head-low gynecology surgery. So what is the way to overcome is to prefer correct, I choose ideal patient. In this case, I've used a Basca mask in an gynecological lap surgery, where the patient is almost head low is given. And there's a suction elbow, we can aspirate the throat directly, and there's a Riles tube, there's a suction tube where the bile is like coming out, and the ventilation is good despite the head low. Our entire tidal volume is set tidal volume is delivered. The airway pressure is around 15 centimeter of water. Vitals are good, saturation is good. The ET soda trace is good despite having a low flows like around 1.5 liters. This is just to show that it can be done, but needs a lot of practice and choice of patients and choice of device. So the solution is to use a second generation device with the oropharyngeal leak pressure at least greater than 25 centimeter of water. Or what you can do is you can test the oropharyngeal airway pressure at the supine normal ventilation in a under pressure control mode, and you keep 8 centimeter above. What you can do is whatever the ventilation airway pressure is there, peak airway pressure in a supine ventilation stage, and you can raise the airway pressure 8 centimeter beyond the maximum achievable pressure in a supine position. That is that if the device is able to achieve such a pressure, that means that they can withstand the laparoscopy surgery. So there won't be any chance of leak or a less chance of aspiration. And try to avoid excessive pneumoperitoneum. Ask the surgeon to limit it to less than 12. Maintain adequate play of anesthesia, paralyzed patient all throughout the procedure, and try to avoid a patient who has gotten poor lung complaints or a delayed GA motility. Again, it's very good. It's careful and under the experienced hand. Coming to use of device in pediatric populations, generally the success rate on the pediatric populations varies around 67 to 90%. The techniques are for a digital insertion. The technique available are the digital insertion technique, which I showed already. Other technique is when the problem with the pediatric ventilation is the tongue tends to move backward, and there is chance of difficulty in placing or a chance of tongue injury or a tongue swelling when it's used in maintain the same position. To avoid such problems, you can do a 180-degree technique like this. So cuff is turned 180 degree towards the palate. Once it enters the pharynx, you can turn and place it in a position. This is called a 180-degree technique. Other one is suggested published in pediatric anesthesia by Pankaj. This is a partially inflated LMA with an inserted laterally at angle of 45 degree against the tongue. This is the technique. Partially inflated cuff, inserted laterally at angle of 45 degree. Once it enters the oropharynx, it's brought into the supine, brought into the routine position. Other technique is you can use a stiletted device. Here I pass the stilet into the airway lumen. It assumes like an ILMA curvature or a nasal oropharyngeal curvature. It's almost 90 degree. Once it's easy to insert, doesn't require your distal fingers to insert it, and remove the stilet once it's done. Take home point with this devices in children is use second generation device with the IO4 oropharyngeal leak pressure and facility to pass an NG tube. Limit the cuff pressure to less than 60. That's ideally it's around 40 to 60. And the better insertion technique to avoid complications will be a partially inflated 45-degree technique, which is quite proven. And finally, coming to use of supra device in a nasal surgery, there's a report saying that fear of blood contamination shouldn't preclude the use of LMA. This just to say that Basca face mask available in the market. So here this is a face surgery where I use Basca face mask, which has got 2 drain tube. Attach a suction tube, suction catheter to the suction elbow, so there's a continuous suction of blood happening. Since there is no tube, the hemodynamic response is less, so there's less chance of bleeding. I mean, there's decreased bleeding as well. The advantage here is this lumen is, I mean, the airway tube is little short and the connector is little bent, so which sits on the chin and doesn't come in the pathway of the surgery or endoscopy. Coming to other important advantage of devices, it's a Bailey's maneuver. The Supraglottic device can be used as a bridging device to extubate, just to avoid the extubation response like hemodynamic or respiratory responses, which is more beneficial in a neurosurgical patient or a patient or poor cardiac complaints or like very low EF, where you want to avoid tachycardia and other hemodynamic responses. In such cases, Supraglottic device can be used as a bridging device. It's called a Bailey's maneuver. Contraindication is to try to avoid this patient who's got a full stomach. How to use it? It is always done in a deep plane and before giving the reversal. There are ways to do it. First, one way is to remove the AT tube and insert the Supraglottic device blindly, or you can keep the device in situ and place the Supraglottic device like this. There's a tube which is still in situ and the device is placed. Another technique is to railroad advanced airways catheter into the endotracheal tube, remove the endotracheal tube and railroad the SGA into it, so that it gives an 100% success rate, and you can confirm it also. This is called Bailey maneuver. And finally, as I said, a device should have two essential requirements and one preferential requirement. The preferential requirement is endotracheal intubation. But with the advancement of newer devices, now it can be used as a conduit for an upper geoscopy or an ERCP procedure. So that's an add-on advantage with the advent of LMA Gastro. Here, this is the LMA Gastro. It's a silicon with a bigger curve, and the tip is a little widened. The tip aperture is widened, so they can pass an endoscope, UGA scope or ERCP scope, so that is inserted through this point that comes out of the tip, and this port is used to ventilate and can be fixed snugly with use of this tape. And this is how it's done. The LMA, this needs a lot of training that has to inserted. With the insertion success comes with experience, and the tip is little wide, and so surgeon needs some experience, quite negotiation to pass on the scope through the esophagus, because the esophageal opening could be collapsed because of the placement of the device. They need some experience to pass on this, otherwise it's quite safe procedure where it comes in between endotracheal intubation and sedation. Sometimes sedation may go wrong in an obese patient. In such cases where you want to avoid endotracheal intubation because of their neurosurgery or a cardiovascular problem, it can be used, but it comes handy with an experienced hand. Here they're able to pass the endoscope through this port quite easily. So this has to be studied a lot, and probably one of the devices for future. Finally, from exam point of view as well as the practice point of view, some of the points to be remembered. For a successful placement and use of a Supraglottic device, patient selection is important. In elective cases or any other cases, right, the contraindication for a Supraglottic device is called, the mnemonic is called rods. It cannot be placed in a restricted mouth opening, or a patient has got an obstructed airway or any mass in the pathway of a Supraglottic device, or any distorted airway and a congenital abnormality or any other issues. Our patient has got a stiff lung, that is, patient has got a very poor lung, so we need a lot of high airway pressure to ventilate such patients. There, the chance of displacement and gastric insufflation is very high. So this is the place you have to try to avoid Supraglottic devices. In emergency situations, Supraglottic device role is mainly a rescue device when the endotracheal intubation or oxygenation is failed. The patient position, the ideal suggested position will be stiffing position, but depends upon the device and the manufacturer's advice. The insertion technique, it's a standard distal insertion technique. It's used for cuff devices. For the device which is preformed shape and always, it depends upon each device and your experience. Fixation, I would like to fix the device first to the maxilla, because maxilla is immobile compared to mandible, because mandible just with the movement, it can be more mobile. It can cause slight displacement. Angle to angle through the maxilla is always preferred. And do not use the gastric channel when there is an upper GA bleed or an excessive airway leak or a esophageal varices, to try to avoid injury to the esophageal varices. And coming to ventilation, limit the ventilation to 6 to 8 ml per kg. Don't try to achieve higher airway pressure. If there is a leak, try to reduce the ventilation tidal volume to 6 to 8 ml, deepen the plane of anesthesia. Airway pressure, which is like try to avoid higher airway pressures and limited depends upon the oropharyngeal pressure of the patient and of the tube and the morphology of the patient and the surgery. And finally, removal technique. It's better to always wait for the full recovery, patient to be conscious, and muscle action if used should be recovered from the muscle action, and till the patient becomes very awake, because patient can still tolerate an Supraglottic device when compared to a critical tube. And final important advice is there are umpteen number of devices in the market. It's not necessary you have to do research, find each and everyone and use one device for a particular surgery or a particular set of patients. Find out what is the best soluble device which is soluble in your area. Try to get familiarized with that and gain enough clinical experience so you can use according to it instead of searching for a better devices. Thank you for your patient listening, and I thank organizers like Edward sir and Rajesh sir for this opportunity. Hope I did some justice. I'm open for the questions, sir.
Thank you very much, sir. Excellent presentation. Dr. Rajesh, sir.
Thank you, Dr. Ramkumar. It was a very excellent presentation. Can you hear me, Ram?
I can hear you, sir. Tell me, sir.
Yeah. I have some questions for you.
No problem.
Dr. Senthil is there along with you?
Yeah, he's there.
First, let me finish. One question is there pending for Dr. Senthil. Senthil,
yes, sir.
The difference between the flexor metallic tube which you showed us.
Yes. The older flexor metallic tube was not having a Murphy sizer. Second thing is the bevel of the tube is little blunt. Nowadays, whatever the flexor metallic tube which is available is little sharper bevel. It's similar to like Parker flex tubes because we are mostly using it for nasal intubation. So for negotiation, the bevel has been little sharper. The second basic important difference is the cuff. The older flexor metallic tube, the cuff is of low volume and high pressure cuff, whereas the nowadays available flexor metallic tube is of low pressure and high volume cuff. These are all the three basic difference between the older and present generation flexor metallic tubes.
Okay, Senthil. Thank you. Shall I move on to the questions to Ramkumar?
Yes, sir. Thank you, sir.
Thank you.
Yes, sir.
You have discussed about the failure, IGL failure.
Yes.
Dr. Prema is asking about causes of IGL failure in failed intubation scenario.
Failed intubation scenario depends upon what's the cause for the intubation, sir. Failure of intubation is then device failure or the difficult anatomy or the oxygenation, sir. If you go as per the guidelines of any Indian Airway guidelines or any UACR, if there is intubation failure, next choice or next point in the algorithm is to use a Supraglottic device. In that scenario, IGL will be an ideal situation because it's already a preformed device and the placement is very easy. And the flexibility of the gel is like it able to mold or like conform to the periodic structure. The seal is also better, sir. One disadvantage is in an emergency scenario, the size of nasogastric tube which can be used through IGL is little smaller when compared to other device. So we can aspirate the liquid contents, but solid content is difficult to do. But at the same time, Bascamas, you can aspirate the solid content directly. But the ideal choice will be depend upon what kind of failure with the intratracheal intubation. If it's going to be unable to visualize or unable to see the glottis, unable to ventilate, again, the chance of failure of any other Supraglottic is always there. But we can try adjust, you can do some maneuvers and try to oxygenate the patient before you get the senior help or the fibrinotic device to actually secure the airway. So it buys the time, sir. IGL is a better choice.
Madam had got a intubation difficulty in patient with Mallampatti class 4. That is where she had a problem in inserting the IGL also. Will that correlate Mallampatti classification?
Class 4, I can agree with the normal insertion techniques. If it fails, we can do this jaw thrust technique or the tongue retraction technique. So the idea is to get the device mask into the oropharynx. Once it is gone, we can push it in till you get resistance. Or what you can use a laryngoscope blade till you can pass on the blade, lift the tongue away from the palate, and you can introduce the mask, sir. So it still will be useful when there is an MPC4 and difficult intubation.
The next question is it the application of gel essential for all supraglottic airway devices? You showed about Busca mask. Is it for eye gel?
For all devices, I mean, I didn't go to each and every step, sir. It is a separate topic. Application of gel is almost mandatory. The advice suggestion is to do a water-based jelly for a smooth insertion of any device, because it has to go along the palate, along the posterior pharyngeal wall, and it has to enter the tip of the upper end of the esophagus and upper end of the esophagus. So gel is almost mandatory. Busca mask, they suggest lubrication on either side, both anterior as well as posterior side, as well as the lip, for easy insertion without opening the mouth. That's the difference with that device.
So this question is from Professor Dr. Edward Johnson, sir. Busca mask, is it available for pediatrics, and various sizes of Busca mask available?
Right now, it's available from 2.5, 3, 4, and 5, sir. Size 1 and 1.5, it's in the process of making. I know Dr. Busca personally, sir. I used to work along with him. He's quite friend of mine. We know there are a couple of changes also, like we used to share and discuss. Last discussion was with him. He's in the process of devising almost device. It has to come to the market. 1 and 1.5 size.
Maximum time, number of time the LMA Classic can be reused.
Classic, it's in silicon, reusable 40 times. The manufacturer advice is 40 times. Because of the solution technique advised is autoclave, steam autoclave. So we have to autoclave up to like 140 degrees Celsius or 137 degrees Celsius for 10 minutes of hold. So because there's repeated autoclave, there is some wear and tear, and with the patient use, wear and tear is there. So company suggestion is around 40. Certain silicon devices go up to 60 times, sir.
One question, I'll combine both. Maximum duration of LMA usage, both with spontaneous ventilation and controlled ventilation. How long we can?
Spontaneous ventilation, it depends, sir. Depends upon the anesthetic you use and the patient's ventilation capacity. As plain depends, opioid usage, the respiratory drive is going to come down. And but so far there is no any textbook or a review article description. So this is the prescribed limit beyond which you cannot use. iGel, the manufacturer himself advised not to use more than beyond 4 hours. We have used for a laparoscopic surgery, combined laparoscopic surgery for like 6 hours. There is a report or a documentation in Benum of up to 12 hours. I mean 9 to 12 hours. There is a report saying that it is used for like 1 day ICU ventilation. But no textbook described or a guideline saying that this is the time limit, because each device, that's a problem with the super devices. There are umpty number of devices with different materials, PVC, silicon, thermoplastic elastomer. So there is no common point, sir.
Can we take this as for postgraduate shake, maximum 4 hours?
iGel, you can go into their recommendations is 4 hours.
4 hours, okay. As you quoted that supraglottic airway devices for LSCS, which supraglottic airway device will be good as a rescue in LSCS?
Sir, from exam point of view, it's ProSeal. Why? Because it's tested. Sir, a lot of evidence saying that ProSeal can be used because of the cuff, the 2 cuffs, because of drain tube, and the experience. Because you tend to use classical LMA insertion technique, so the same technique applies to it. So easy to insert, provided it should be available. But again, I suggest if any other supraglottic device with a drain tube and with a very good oropharyngeal leak pressure, more than 30 centimeters of water, that device can be used. This is only the device part. The other part is the patient side, sir. How fasted, how emergency, or twin pregnancy, manipulation of abdomen, position of neck, all this come to the play, which is non-controllable. The controllable is the device, that is second generation device. ProSeal is time tested, sir.
Okay, one last question, Ram. Is when we use muscle relaxants in a patient with supraglottic airway device, should we reduce the dose of muscle relaxant?
It's like no major difference, sir. Once you reduce, my suggestion is to use, if you find it like going to be difficult insertion, you can use the full dose of the intubating dose of the first attempts, and the subsequent maintenance is not required. Because even if you reduce the dose, so if instead of like 0.5 of atracarium, use 0.2 milligram per kg, but the waiting time for the muscle recovery to occur, you have to wait for the same duration. So what we suggest is to probably use the first dose to the full, and you try to avoid, or you time it, or you based upon the patient's recovery and the movement, you can give this, you can avoid the subsequent doses. But again, there is no like textbook recommendations to say that you cannot reduce use, because you may end up in inadequate plane again. If it's for laparoscopic use, I can cut and try say you can use full dose. You want muscle relaxation for the surgical purpose.
Thank you very much, Dr. Ramkumar and Dr. Senthilkumar, because both of you have brought a workshop this thing to us on our screen. It's excellent presentation from both of you, and most useful for all the postgraduates. I think almost I covered up all the chat questions. If at all anything is being left, I'll personally message you and get the answers from you. Edward sir, do you want to add up any points?
No, sir, nothing else. Sir, wonderful presentation, sir. Thanks. You are loaded with some practical tips. So that is a highlight of your presentation. Thank you so much. And the participants' questions also are excellent. That shows the participants' involvement in your presentation. So thank you so much, sir. So with that, we will come to the end of this session. We will meet next week with critical care topics. Thank you, Rajesh, sir. Thank you,
sir. Thanks.
And also I thank the A1 Logics, Acrola sponsors, and also Anesthesia TV. Thank you, Ananda. We will meet next week.
Thank you.
What?